Hi everyone, welcome back to the Transfusion Vital channel. So today we will be discussing about the physiology of apheresis. Of the apheresis, it depends on the three factors: the anticoagulant we are using, fluid shift, and the cellular loss. Commonly, we will be using the citrate as a primary anticoagulant for the apheresis procedure. It will chelate the calcium and it will block the calcium dependent clotting factor for the reaction, which ensures the extracorporeal blood remain in the fluid state. In addition, it will release the PTH in response to the decreased ionized calcium level. This will result in the mobilization of the calcium from the bone, increase the intestinal absorption of the calcium, and increase the reabsorption of the calcium by the kidney, thereby help in maintaining the adequate circulating calcium level. Despite these compensatory mechanisms, in some individuals, the decreased ionized calcium level can result in the symptomatic transient hypocalcemia. Anticoagulations. So anticoagulant like ACD, acid-citrate dextrose, it will chelate positively charged calcium ion and blocks the calcium-dependent clotting reaction. It works extracorporally and these are metabolized in liver almost immediately upon the return. The side effects include the transient hypocalcemia. Decrease 0.1 millimole per liter for each 0.5 to 0.6 millimole per liter rise in the plasma citrate. The dilution, redistribution, metabolism, and the excretion of the infused citrates are important factors protecting against the profound hypocalcemia. So this illustrates the relationship between the citrate level, ionized calcium, and the PTH level during the platelet apheresis. Heparin, it can also be used as the anticoagulant, so it will prevent the conversion of the fibrinogen to fibrin and prothrombin to the thrombin. It has been used in the open heart surgery during the cardiac bypass ICU to prevent the coagulation in the vascular access devices. Blood collected in the heparin need to be transfused within the short period of time. Therefore, it is a poor choice for the anticoagulant of the blood component derived from apheresis. And the side effect is HIT, heparin-induced thrombocytopenia. The difference between the citrate and heparin. So in citrate there is no systemic anticoagulation, no risk of bleeding, whereas with the heparin as an anticoagulant, there is a risk of bleeding and the systemic anticoagulation can be happened. There is a risk of hypocalcemia related complication. Ionized calcium monitoring may be necessary for the citrate. For the heparin, there is no risk of hypocalcemia. For citrates as an anticoagulant, there is no risk of hit, but with the heparin, there is a possible risk of hit. For citrate, there is a slow flow rates. For heparin, faster flow rates need to be maintained. There is a risk of metabolic alkalosis for the citrate and no metabolic alkalosis seen as a heparin anticoagulant. Then there is an increased risk of citrate related reaction with the use of citrate blood component during apheresis and no additional risk of citrate related reaction seen in the heparin as an anticoagulant. There is rapid reversal with the calcium supplementation and there is a rapid reversal of heparin anticoagulant with the protamine. The half-life for the citrate is variable, whereas half-life for the heparin is 90 minutes. Next is fluid shift. So during the apheresis procedure, change in the intravascular compartment occurs secondary to the removal of blood into extracorporeal circuit. Hypotension occur because of the depletion of the intravascular volume and it can also be due to the vasovagal reaction. So what happened during the vasovagal reaction? The parasympathetic nervous system that will override the output of the sympathetic nervous system, which will result in the hypotension and decreased heart rate. So factors associated with the vasovagal reaction in apheresis donors can be, it will be seen more in the female teenager and in the whole blood donors as compared with the adult male and apheresis donors. To minimize the risk of hypovolemia, we have to limit the patient extracorporeal volume to less than 15% of the total blood volume of the donor. The ECV is a dead space. That means the tubing and the chamber of that instrument, which range from 15 to 800 ml, that need to be filled to complete the apheresis circuit. So priming the instrument with the colloidal solution or with the properly mashed RBCs can be done to minimize the risk of hypovolemia. An alternative bolus of saline and the colloid solution can be given to the donor. Third part is the cellular loss. So in platelet donation, platelet count decreased by 20 to 29%, and among females this decrease tend to be greater. For granulocyte donation, the HCT decreased by 3%, platelet count decreased by 22%. HES prolongs the APTT time and decrease the factor 8 level. In plasma donation, regular plasma donation twice a week result in decrease in the serum protein, globulin, IgG with increase in B cell, decrease suppressor and NK cells. What are the adverse effects? Adverse effect includes citrate toxicity, hemolysis, vascular air embolism, vasovagal reaction, depletion of the clotting factor, hypovolemia, circulatory and respiratory distress, allergic reaction, TTI, lymphocyte loss, depletion of protein and immunoglobulins. Next is your citrate toxicity. If the amount of citrate infused exceeds the body ability to metabolize it, the level of ionized calcium decrease and the donor will feel the numbness and tingling around the mouth. So if this donor is unattended, then it can lead to the tetany and cardiac arrhythmia. Citrate can also chelate the magnesium and the hydrogen ion, which can also lead to hypomagnesemia and alkalosis. How we manage it? We can give the calcium supplementation per ROS for the prevention. And for the severe cases, you can give IV calcium gluconate 10% or calcium chloride in 100 ml of NS for 25 to 30 minutes. For TPE procedure, calcium gluconate plus 5% albumin can be given. As you can suspect hypomagnesemia in the patient, you can give the magnesium supplementation in that patient. Vascular access, insertion of the large IV catheter can lead to bleeding, hematoma, sepsis, and phlebitis, neuropathy. Vasovagal reaction, if there is a vasovagal episode, there is a feeling of malaise which is mediated by the vagus nerve, which can lead to syncope or fainting. Hypotension can be encountered due to the depletion of the intravascular volume. Hypovolemia can be seen more with the intermittent flow centrifuge instrument as compared with the continuous flow instrument. Allergic reaction can occur. It occurs because of the replacement fluid in the TP procedures like albumin or FFP. Hemolysis can be seen. It's a mechanical problem with the equipment, or there's a kink in the plastic tube where you can have this hemolysis. Thank you. Like, share and subscribe the video.